one of our most popular speakers, always has been, is this young woman on my right.
He's a flatterer, isn't he? He does it so beautifully.
Yeah, young Yvonne. And she is, as we all know, a retired palliative care specialist, and she's given us wonderful insights over the years and helped a hell of a lot of people and their families. So without any further ado, Yvonne.
Thank you so much. That's really good. Well, how lovely. I love to be here. It's always a lovely group, the prostate group here, and I see some faces that I've seen before too. Now, this is an interesting topic, isn't it? Not one that would get you out at night. For one thing, who wants to talk about palliative care and dying and all the things that go with that? And then facts and figures, pretty dry. So I'll try to make it more interesting than you think it's going to be, perhaps. I started to be interested in palliative care back in 1958, when I was 18 years old, and I always wanted to work a little bit in the holidays. So I got a job, my very first, at Naringa Hospital for a month on night duty. So they had to teach me, as a nurse, they had to teach me what nursing was all about, and what a thing it was in those days. We were in the new building, which had been built 3 years previously, but there was also an big old ward at the back, which had 20 patients. You know those big old wards with all the patients lined up by the side? And at night, it was really a hellhole. It was quite extraordinary for an 18-year-old to see what happened in those wards. I was fascinated. I was so keen. I'm about to start university, about to start medicine. So I'd go through the patient lists with all the diagnoses. And some of them were cancer, but a lot of them were senile dementia and senile decay and that sort of thing. So it was really more of an old people's home in those days. It wasn't really what we know of it now, by any means. And during the night, I'd go around and we'd have to do backs. But it was tricky because some people had what they called restriction sheets on them, which were to tie them into the bed. So the sheet would go right across the top of their chest and would be tucked in very firmly at the sides so that they couldn't climb out of bed or fall out of bed. I don't know whether they had cot sides like we have nowadays. They must have had. But these restriction sheets just kept the person lying flat on the bed, unable to move. And I don't honestly know how they breathed. And sometimes we did come and find someone hadn't breathed for a very long time and was actually dead. So I learned all the things. I'm giving you all the lousy end of it, aren't I? I learned all the things about laying people out and pans and all of that stuff and doing people's backs. But the best job of the place was that during the night you had to prepare the breakfast. And the breakfast involved getting the butter out and cutting it up into pieces and letting it warm up out of the fridge so that people could serve themselves. And then we used to get the trays, and there was a garden there, and we'd go out into the garden and pick some flowers in the dark and bring them in, and each person would have a little egg cup with one flower in it on their tray. And you'd go around in the morning with the tray, just before I went off duty, with their breakfast on it. So then I did university and graduated and started a general practice in Wahroonga. And I wasn't there very long before I was asked if I'd like to be a doctor at Naringa. And as a VMO, a visiting doctor, and I immediately said yes, because I was really interested to see, you know, what it was like. And I did like that intimate thing that seemed to come with people being in difficulties. And I started working there. It was just a visiting thing, so I was to visit once a week, but I very quickly started visiting every day. And the situation then in 1968 was that there was no understanding of any pain management like we have now. It was utterly, utterly different. There was only one understanding, and that was you tried to keep people comfortable, and you tried to keep them comfortable by giving them an injection of morphine, enough. You had to make sure it was enough, so a fairly big injection. And so the patient's experience would be that they'd have pain and they'd have to ask for something. And after a while, you know, the nurse would come. Even in the best circles, nurses don't always come when you ring the bell, do they? And then she'd have to go out and she'd have to get another sister and they'd have to check the thing. And so it'd be quite a long wait, maybe an hour, 2 hours, 3 hours, 4 hours, before the person would get the medication. And then it'd be quite a lot, so that person would go to sleep. It'd knock them out. And after morphine, it'd be morphine, of course, after about 4 hours, the morphine would wear off, and the person would wake up in pain, and they'd go through the whole sequence again. I didn't really know anything better than this, and I made sure I wrote drugs enough to make sure that people got it when they needed it. And I tried to get the nurses to do it more conscientiously. But you know, it's so wonderful when things just fall into place. My husband's an anaesthetist, and he wanted to go to the pain conference in Florence. Well, who wouldn't want to go to pain conference in Florence? So off we went, and there was the first palliative care report. It was actually the first ever pain conference, International Association for the Study of Pain. And there were reports about palliative care. And they were talking about morphine only lasts 4 hours, cancer pain goes on all the time, so you've got to make sure you give it every 4 hours. Great understanding. And then I went to visit St. Christopher's Hospice, which was famous because they had started this wonderful 4-hourly morphine. And it was fantastic because it just was staggering. I met there the woman who'd invented this thing, this understanding, and she took me to see a patient sitting very comfortably in this beautiful room, looking out at the garden, completely comfortable. And we talked to her for a bit, and we went out then, and the doctor who was showing me said to me, "Would you like to know how much morphine this lady is on every 4 hours?" "Yes," I said. She said, 260 milligrams every 4 hours. Now, the normal dose that I knew about was 10 milligrams. So the thing she taught me was, you just use the morphine as much as is needed, and you gradually increase the dose, not to make the person unconscious like my other patients had been, but to make them quite comfortable so that they just had enough to balance the pain. And frankly, this is one of the most important understandings that we have still about pain management. The idea is, if it's a pain that doesn't come and go but is there all the time, you have to not have the medication come and go, whatever it is, if it's morphine or some of the newer medicines or even Panadol. You know, you've just got to make sure that it doesn't go away, if the pain doesn't go away. So you cannot imagine how much trouble I had convincing the old codgers back at Naringa. I'm sure they're all dead now, so I can say that, can't I? And now I'm an old codger. that this was a good idea. It was going to kill the patients. It was too dangerous. It was really, they couldn't bear to do it, and it took a long time. And I was just so fortunate that I got a matron, a new matron there, who very quickly understood and very quickly helped me to push it forward so that it was part of the routine. But it was so interesting because we didn't understand any more than that. And we didn't understand, as we do now, that there are a number of different kinds of pain. You know, you can have pain because you've got secondaries in your bones, And that means that whenever you move, it hurts more. So it's very difficult to have the same amount of treatment going on when you're still and when you're moving. This flummoxed us really for a very long time. And it wasn't until we learned it from others, again, that you've got to use special medications that act at the site of the pain. Things like Panadol and the non-steroidals, the things that we use for arthritis, which also has to work when you move and when you're still. So those things were again new understandings as the years went by. And as a few years went by, it was about 78 that Pam Ludowici, who was a chaplain up at the SAN, asked me if I would come across to the SAN. They'd had the case of a doctor here who died very, very badly, and it was quite dreadful. They had no new understandings about palliative care here at that time. So that was when I started to work at the SAN, and I came here as well as to Naringa. And gradually we learned about the other kind of pain, which is pain which affects the nerves. And I don't mean the nerves, I'm a nervous, skittish type. I mean the nerves, like the nerve that runs down your arm, you know, your funny bone nerve. You know why they call it the funny bone, don't you? When you hit it, it gives you this shiver down your arm. Do you remember, have you ever had that? It's the nerve that just goes round the corner here, and when you hit it, it hits the nerve against the bone, and it gives you this really unpleasant, sickening, shivering kind of feeling down your arm. So what we've discovered about that is that the treatment for that is, again, not lots and lots more morphine, but it's the various drugs that affect the transference of pain impulses down nerves. And the typical one of that is the anti-epileptic drugs. So over the years, we've got into better and better and better drugs. Back when I started at Naringa, we were all visiting doctors, and we were all GPs. And gradually people like me specialised in palliative care and only did palliative care. I stopped being a GP after a few years and only did palliative care. And gradually a specialty developed. But it took until almost 2000 before it became recognised fully as a specialty. So we've been very slow growing, but we're getting better. And I'm not sure what happened in New South Wales. It spread all over Australia gradually. Western Australia developed a very good system, which they still have. Somehow a charity got going called the Silver Chain. And the Silver Chain charity has been going now for 30 or 40 years, looking after people mainly in their homes, ensuring that they have medical and nursing and social work and psychological, all those supports in their homes. And they've done very, very well. And it's very much impressing people over here. We don't have that. We're very hospital-based. Now you'll know about hospital in the home that's getting going out of the SAN, perhaps. You know, the government's very keen for us to have more things happen at home, because with our aging population, we're getting to the stage where hospitals aren't going to be able to manage unless they're kept for just the very special things, heart surgery and intensive care things that need, and surgery, and things that maybe renal dialysis and that sort of thing. So it needs to be really kept, if we can, for those things, so that there's enough of those things. So the government's really keen for people to be kept at home, and that thing that's happening with Silver Chain in Western Australia looks very good. But really, New South Wales, somehow something went wrong for us. All the other states seem to have developed really good specialists and nurses, and they've got funding, and they've been able to provide palliative care, and things have gone quite well. In New South Wales, it seems our funding just has never kept pace with the work. So the funding that we had 20 years ago hasn't really improved all that much. and yet the workload has improved and increased enormously. You know how much the population's increased in that time, and the aging population much more. I retired in 1997, and so that's quite a while now. And when I retired, I'd been for 5 years the community doctor for Naringa. So I used to go around visiting patients in their own homes in Hornsby and Ku-ring-gai, and it was great. Loved it. There was so much you could do. And I'd go and see people once a month, and then once a week, and then every day if I needed to. And there was enough time to do it. I could do that. And then when they needed to, could come into Naringa, and I'd look after them in Naringa. And we had nurses that went out and did similar things. They helped and set people up, made sure people had everything they needed at home. And we had occupational therapists who went out and made sure the bed was right and the chairs were right, and there weren't cords all over the place that you were going to trip over, and that you had a wheelchair or oxygen concentrator. And we had physios who came out and showed you how to breathe better and how to move better. People who've got very bad breathing, there are really a lot of things that physios can do to help them, surprisingly. And when I retired, it was pretty good. I thought we had a really good service, and people were able to be kept at home quite a lot. Some had to come into hospital because their wife or their husband got exhausted and it was just too hard, but mostly they were able to stay at home. Now, I started, as soon as I retired, Pam Ludowisi, who'd roped me in the first place at the SAN, roped me in again to join the cancer support group, one of the cancer support groups. So since 1997, I've had a spot together with another very good person with the Wednesday group, which is the group of people who've mostly got advanced cancer. But it's also a mixed group. It's a group of people with all sorts of different cancers. It's not a specialized thing. And that's been great. Now, 2 years ago, at the beginning of 2011, I used to always say to patients, everything's going to be all right, just get the palliative care team in and this is what they'll do. And I'd tell them what I used to do. They started saying, no, we tried to get them in and they couldn't come because we weren't sick enough. I only had pancreatic cancer, and I was only 88, and my wife was a bit frail, but they couldn't come. So I looked into it, and on New Year's Day of 2011, I was told that the community service that I had worked for had closed. It wasn't actually true. It had only shut down to half strength. But in a way, a switch went off in my head, and I thought, well, I'm going to have to do something. Nobody else seemed to be doing anything. And so I learned advocacy, which is something quite wonderful, really, and it's something as a sort of a second career, I have to tell you, I recommend to you. It's really quite good fun. I had no idea what to do, but I thought the first thing to do is to write to the local member. And the local member in Hornsby was Judy Hopwood. She was the person that I'd been told was someone who was interested in palliative care. So I did. And the Libs were not in power at the time. She immediately wrote to Barry O'Farrell, who was, of course, opposition leader. And he sent the letter on to the health minister of the time, Carmel Tebbit. And she sent a letter back, and it all went round in a big circle, and it all was complete rubbish about why the services had been dropped. There were all sorts of dreadful explanations. So then I started the petition, and it was great, and lots of people helped, and the SAN people helped enormously. So we got lots of signatures, and I talked to all the politicians, and we eventually collected 24,000 signatures, and we went to Parliament, and by then the Liberals were in, so they could say that Labor was the bad ones, and they'd done all these bad things, which they had, and they promised to give the money back, and they did. And at the same time, I asked in the petition to improve palliative care throughout the rest of Australia. So they promised that they would. And that's been the next 2 years' work for me, because it was clear that unless something was done to keep pushing, nothing may happen. But the health minister, I have to tell you, is very good and very interested in palliative care. She told us in Parliament that she had sat holding her best friend's hand in Naringa in the 1980s as she died, and it was so wonderful that she was all for palliative care. So we've got somebody on side there, it seems. But you know what happened with the finances? Things got bad. We all know they've got a bit bad in Australia and very bad everywhere else. So everybody started saying there's not going to be any money. So then at the beginning of last year, I realized that we'd have to have another campaign. And I started again with a petition, and I happen to have brought the petition with me tonight in case any of you have not signed it. But by the end of last year, we had collected 60,000 signatures. And again, we had a debate in Parliament, and the health minister didn't say that she was going to do any more than she'd already done, but she did say that she'd put out a plan, and that the plan basically said that there would be more coming. So we're waiting for the more coming. In the meantime, back in November last year, and that was when we went to Parliament, the Australian Institute of Health and Welfare, and this is where the figures start coming in, brought out their report on palliative care. And in that report, they counted the number of palliative care doctors and nurses in each of the states. And to our amazement, we found that New South Wales is 41 palliative care doctors short of the average of the rest of the states, not the national average, because New South Wales drags down the average, and 300 palliative care nurses short. And when I started to get onto the rural areas and rural nurses, because it's all nurses out there, there are no palliative care doctors in western or southern New South Wales, the whole area, it's nurses, and it's isolated nurses in little towns all over New South Wales, and the bigger towns have got maybe 2 or 3 nurses, so it's not big. They'd started giving me their list of complaints, that they didn't have relief when they went on holiday. So what would happen when a nurse went on holiday? Another nurse from maybe 500 kilometres away would cover her by phone, so that patients could ring her, but that was the best they could do. There was no 24-hour cover in New South Wales outside the metropolitan area. It's quite extraordinary. And when I looked into the money, that was nice too, interesting, I found that Victoria has much more funding for palliative care than New South Wales. And I'm not talking per head of population, I'm talking little Victoria and big New South Wales New South Wales has got less funding. Quite extraordinary. If we were to have the same level of funding per head of population or per death rate, we would have 70% more funding for palliative care. So that's all the figures. You can relax now. Things are bad in New South Wales as far as palliative care goes. And let's think about why it is. First of all, palliative care is generally done by people employed by the government, not by private doctors, and not by private nurses, and not much by private hospitals, although we have got palliative care here. That means that they can't speak up. And in fact, it's been very difficult to publicise the campaign to improve funding for palliative care, because the people who know most about it can't say anything. Neither the doctors nor the nurses. They've been restrained. Whereas, how many neurosurgeons do you know who aren't self-employed? How many orthopedic surgeons or urologists are not self-employed? They can say what they like, and do, and loudly, and they should, and sadly we should. So there are very few people, except those who happen to be long since retired, who can say anything about how bad things are. And the people can say, because that's the other thing. I was told quite early on that 200 votes can swing an election in the state parliament. Now, when you get 60,000 signatures from all over New South Wales, and I can tell you, 4,500 just from Wagga, one town, almost a tenth of the electorate, that starts to impress people. I was down in Bega 2 weeks ago, and I'd just like to give you a sort of a snapshot of what Bega's like. The Bega Valley spreads out down to Eden, down to the coast, down to the border, and it runs up along the coast to, can't remember the name, it's not Marimbula, I can never remember, halfway up, almost to, yes, thank you, almost to Narooma? Narooma, thank you. Narooma is just out of the Bega Valley. Thanks very much. So it's a very big area. How many nurses do you think they have? Half a nurse. So a nurse working 20 hours a week has to cover this vast area with 34,000 population and 300 deaths a year. That one nurse has to look after those people. Extraordinary. And they've had that number for the last 15 years. They've never increased it. In the same period, they've increased aged care nurses 5 times. Extraordinary. So we have to think really, what is it? Maybe people are prepared to accept, politicians, that we age. They've got the message about the population's aging, but they don't want to think that bad word at the end, that they're going to come to the end of their lives and they may have troubles getting there. You know, it doesn't have to be difficult or painful or helpless or undignified. It really doesn't. But people need to know how to deal with it. And that's really what palliative care does. What palliative care really does, in my experience, is to walk with the person through this period, whether it's the last 6 months or the last 6 days or the last 6 hours. It's saying to the person, you and your troubles are my first thing, my first interest, my highest priority. Not what I'm having for dinner or what happened last week or the next patient coming in. However long it takes, I'm going to be with you, and I'll make sure it'll be all right. Now, you know, for me to think that somebody could do that is fantastic, because I would hate to think that I have to battle or struggle for help towards the end of my life. But I can tell you that in the Bega Valley and in many, many other parts of New South Wales, that's the case still. So we have to keep advocating, and I must ask you to sign the petition. And I'd like you to ask me lots of questions.
Alan Lawson is my name.
Hi, Alan.
You mentioned that the aged care nurses are increasing in numbers, probably because of a political push and so on.
Yes.
What are the practicalities of training those people to also be palliative care?
Yes, it's a good idea if there are spares. It's not a bad thing to do at all. Training people to do palliative care varies. You can train somebody by taking them with you and they go around and they've got to, you know, experience it really and be taught the different techniques and the different drugs and the different way we do things and the different way we sit by the bed and we don't stand at the end of the bed and, you know, in a white coat and that sort of thing. But in order to train, if we were to say, okay, there are the 5 specialist aged care nurses in Bega, we could train them. Who's going to train them down in Bega? That half a palliative care nurse? That's the difficulty there. We really need to have somebody brought in to Bega who can be specially for palliative care. But it's a very, very good question, because it's very important that anybody who's coming in contact with aged care should know a little bit about palliative care. One of the big issues is in nursing homes that we need to have much better care at the end of life, and the staffing isn't very luxurious in nursing homes. There's a wonderful thing happening down in the Southern Highlands. There's a palliative care nurse there who wanted to stop working for the government, and she's become a private consultant. And she consults 2-3 nursing homes there. She goes to each one for about 5 hours a week. And she sees anybody who's approaching the end of their life, and she makes sure that the nurses understand the symptoms and what might be needed. Various things. For instance, she told me that she had one man there who had a cancer that was growing out of the side of his neck and was oozing, and pretty difficult thing, you know, quite a specialized thing to look after, and with pain. And she got that all under control to the extent that he didn't need to go to hospital at all for the whole rest of his life. The nurses there understood. She came regularly to make sure, and that all went beautifully. At the same time, there are other sorts of things that somebody who has specialist knowledge can guide and show and teach and influence a type of care. You know, a type of care that's caring, that is considerate and has, you know, those concerns, something you don't walk away from, you just have to deal with.
So, Yvonne, Pam and I have learnt a lot from you over the years, and the thing that amazes us is that there's still people out there that think that because they've got what they've got, they have to suffer pain.
Yes.
And, of course, you know, we tell them they don't. No. And the other thing is that you informed us long ago that people that are undergoing various chemotherapy regimes suffer from nausea and all these things. Yes. And that's another area where palliative care helps, isn't it?
Very much, very much. It's very interesting. I'm really glad you raised that, because I think, you know, I'm glad I told you about how it all began for me, because the understandings that people had back then in the 1950s and 1960s, so long ago, when we were all young, they're still the sort of myths that people are bringing now about the sort of life we have to live. It is absolutely true that there is no need to suffer pain, that almost, I have to say, 99.9% of pains can be controlled. And when they can't, in that 0.1%, there's much that can be done to make it easier. But it's the aim with palliative care and pain control is really to make life better, not to take any away. So we don't want people to be groggy. These are things that everybody worries about. They don't want to be drugged out of existence. People want to go on living as long as they can, and that's our aim, to enhance life as much as possible so that you can live to the very last breath. We had, I must tell you, a beautiful man in our cancer support group. He was 40, and he had a really horrible cancer that was metastasized all over his body, multiple organs, and in the skin as well. So he had lumps all over the place, including in his tongue. Terrible. And he was the most beautiful man. He came to our group all the time, and he had very good pain management and wonderful treatment generally. But gradually you could see that the end was going to come, and he saw it too. First he took his family to his home country for a holiday. Wonderful success. Then he got sicker, and he had his own wake, before death wake, which was great, and got everybody together and told them what he wanted them to do after he was gone. And then he gradually came to the end, and he wanted to die at home, and he did. He was quite lucid a few hours before he died, and he went to bed and with his wife. They slept in the same bed. He went to sleep, and he died during the night while she was asleep beside him. She woke up at 2 a.m. and found him asleep. What a way to go. Perfect. And because of this really careful, perfect management, and because of the way he was. And we all went to his funeral. And at his funeral, he'd written what he wanted to have said. And so the coffin was there at the front of the church, and he said, "Now I'm speaking to you. I can't actually speak with my own voice, but another will read it for me. And I want to tell you that the first time I was in this church, I was where I am now. And walking down the aisle came the most wonderful vision of loveliness, my wife." I mean, we all broke up, of course, and he then went on telling us what he wanted from the children, how he wanted them to look after their mother, and so on. It was really fantastic. I commend it to you. A number of our other group, the rest of our group, sort of thought that they would like to do similar things. You know, it was so impressive. Really good.
Adele?
A couple of things, Yvonne. Graham's mother at 96 passed away while we were overseas 3 years ago.
Yeah.
She lived in hostel care, not in a nursing home, but in hostel, and his sister was there with her when she passed away, and our daughter-in-law was as well.
Great.
And you're talking about aged care nurses. The aged care sister who was on had no idea about palliative care. It happened to be the sister who looked after that sort of thing was not on.
Yes.
So I think it's really needed in these hostile situations. Yes.
Very.
And it was a terrible time for Graham's mum.
Oh, really?
But anyway, but the other thing is, on the radio today, I heard something about the federal government is taking away funding for 54 palliative care.
Yes.
That is correct?
Yes.
That I heard that?
Yes, yes. What happened was that 4 years ago, Kevin Rudd, it was Rudd then, he brought out this 500 million enhancement funding for subacute care, of which palliative care is called subacute care. There are a number, rehab is also subacute care. And it was divvied up, and palliative care didn't get much, but they got enough for 51 positions throughout New South Wales, or 54 positions. And it expires on the 30th of June. And the federal government has not said that they'll continue it, and they're not likely to. So that's what that's all about. And it's very, very bad. And I just learned today that they've got a nurse in Dubbo doing exactly what you said, going into the nursing homes and ensuring much better care. And she's going to lose that job. Tragic.
That's no good.
Is there a substantial model difference between, let's say, the approach that the SAN takes versus the public system?
A little bit, frankly. I think that because we're an active acute hospital and most of our palliative care is in hospital, our palliative care specialist, Gillian Rothwell, is very, very good. We're very, very fortunate to have her, terrifically fortunate. But she's working in with the oncologists and surgeons and is careful not to tread on their toes. It can be that more active treatment goes on for longer into the course of the illness than might be happening in the public system. Mm-hmm. Now, it's really a very interesting issue because, you know, I've got somebody in my cancer support group with ovarian cancer, and last October, not in 2011, she already had a bowel blockage, and she was up there, and in the days when I was working, she would have died of that blockage. Now, because she was in the SAN, a surgeon operated on her, made an ileostomy, which was like a colostomy, an early colostomy. She hated it, by the way. And then she had chemotherapy for a number of months. The chemotherapy reduced the cancer. She was able to have the two ends of her bowel connected up again. This lady's still alive. She's still at home. She's a little further down the track, but she, you know, I don't know that she would have, I don't know how that would have gone in the public system.
Doctor, I'd just like to know, we've got an elderly couple who lives 3 or 4 doors down from us, and the lady's now got pretty much advanced emphysema.
Right.
And the family are looking after her.
Right.
But I know the husband's getting terribly confused because one of the eldest sons will know all about everything, no matter what. And the other daughter comes in there and he's just getting totally confused. Who would organise for a nurse to come if there is one in North Ryde?
There would be.
A doctor has to organise that?
Yes, the GP has to refer her to the Sydney Home Nursing Service, and there is Sydney Home Nursing Service in Ryde, and they're very good.
Well, I see a lot of them when I'm walking. You see, obviously the nurses going in, but they don't seem to be getting much outside help. They're still bathing her and showering her themselves, and she's getting weaker and weaker.
Wow.
And I just think, wow, somebody shake them into singing out and doing something. I thought the doctor should do something.
The doctor should be, or well, you know.
I know she's had a physio in to organise the house a bit better.
Great.
Not much, but
good.
So can they do that themselves, or?
The doctor has to refer to the Sydney Home, and then Sydney Home can make suggestions too. And I think that they should be asking palliative care to come in.
Indeed.
Because that's something that they do.
Yeah, thank you.
They can. But I must say the community nurses are pretty good at palliative care in a lot of the areas. Certainly in Hornsby, they're terrific.
Yeah, well, the husband's 89 and he's looking after himself most of the time.
Wow. And this is the thing, you know, the government might want people to be everyone kept at home, but when you're an ageing couple, it's not that easy. But it can be wonderful, Frank. I have to say that when you have a family with sons and daughters like that, working together, it can bind a family together for the rest of their lives. It can really be good. Or it can be problematic.
Now, Yvonne, why don't we use this opportunity to let people know that are going to see the video in New South Wales and in every other state and territory around Australia. If you want them to sign this petition, where could they go? They
should send me an email to Yvonne McMaster, YVONNE, MCMASTER, no dots in between, at tpg.com.au.
Right.
That would be marvellous. And then we can have a conversation and be wonderful. I love to be
Now just repeat the email again so that everyone hears it.
Yvonne, YVONNE, MCMASTER, at tpg, T for Trevor, P for Peter, G for George, .com.au.
Excellent. So we'll get that message out across Australia.
Thank you so much.
By this support group, which is great.